one of the things that comes out from reading all these papers, and the first one kind of says a lot of it, is a tremendous disparity in resuscitation rates. You know, in some communities, you cannot die. You know, this is Seattle, Washington. And some you cannot live. Los Angeles and New York, that kind of stuff. And so they just make that point in a lot of these. There's some interesting statistics in all of this, but they had, in this one, a 3 to 16% difference in survival. And they speculated maybe it's really due to response time and that kind of stuff. The trouble with a lot of this literature is they assume all cardiac arrests are alike. As I mentioned in my preliminary talk, just because you have a cardiac arrest and this patient has a cardiac arrest, one survives and one doesn't, are they otherwise normal, otherwise equivalent rather? Does one have severe heart disease and, you know, other things? And then the other thing I have never seen mentioned in any of these papers, and some I've read the originals on, but I got to admit not all of them, is how about the idea of withdrawal of life support? You know, most of the time I think the measure of efficacy in this kind of stuff is useful survival to hospital discharge. All these other surrogate markers of, you know, pulse after 4 hours and getting to the ICU, they're all sort of interesting things, but really survival is the one that you're thinking about. And in some people who aren't waking up especially and are critically ill, you know, a lot of times the family finally comes in and says, you know what, granddad's going to die, it's okay, let him go. Do those get included in these statistics or not? I don't know. They don't actually mention that. So number 2 here in Los Angeles, survival is about 1.5%. The next one, in CPR, does technique really matter? Read what Billy Mallon had to say here. I'm pretty bold, but I don't know that I'll actually read that out loud. But what they say you really need to do good CPR is it's got to be fast and deep compressions kind of thing. This is their opinion. You know, the question is, what is CPR doing anyway? Is it making some blood flow to kind of tide you over until you get your heart started again? Is it priming the heart to get ready? Is it keeping the brain alive during the meantime? So there's a bunch of papers in here that basically bash doctors. They study it in some way to see what kind of CPR they're doing, and they find out they don't do it very well. Okay, message done. The only one in here that I actually thought was actually a take-home message that we can learn something from in our practice was number 6, where one guy was doing CPR and he didn't have rubber gloves on, and the patient had an implanted defibrillator that went off, and he got defibrillated. So that, to me, is a take-home message, and most of the rest of us, you know, this is the save yourself.
Is that a real risk?
What? Is that a real risk? I don't know. We didn't mention in the case report stuff here what I've always quoted at some point in the course is what's called Hoffman's Law of Case Reports.
They still sleep with their wives, right?
Yeah.
With their husbands.
I guess, and I don't know. But if you're doing it and setting it off, I guess, is the thing. The Hoffman's Law of Case Reports is that if anybody writes up a case report, you can be sure that you're never going to see that. Don't worry about it. That's why it got published. I mean, people write about it because it's so rare. You don't have case report, alcoholic fell and got a subdural. You might write a case report, alcoholic fell and didn't get a subdural. Now there's a case report. But so it is very rare and that kind of stuff, and I'm kind of putting it down a little bit, but that's the case report stuff. All right, how about compression only? Will a CPR device, you know, the thumper kind of thing. You remember that from years ago, this giant piston, that you put somebody under this giant piston and it was just cranking away at them. Anybody use any of these devices?
Yeah. Cool.
No, currently. No, of course not, right, yeah. What's that? Right. Do they live? Can't put it on a dead person and make them live. Thank you. That's right. Good. The thing it does is it frees up your people to do other things. That is one thing here. So there's some evidence that they might get a little bit better. A lot of these are sort of a band device that does it, and they do a before and after study. As I've mentioned to you, I have great reluctance to accept a before and after study. You know, up until last month we did CPR one way, and now for the next year we did it a different way, and our outcomes were different. Well, maybe you did a lot of other things differently too. Your patient population changed. I don't think that's much. 10 is an interesting one here. This is at least slightly spinning. What they did, this is Zoll, they have this automatic device that does this. And so their endpoint was survival to spontaneous circulation 4 hours after the 911 call. That's not unreasonable. You know, they probably can't be responsible for you forever, but then they don't look at survival to discharge because maybe that doesn't work. You know, the links in the chain thing here, this is, I know Ricky has this theory, you know, if everything, the links in the chain aren't adding up, then you're not going to get survival. And those of us who think survival is the only one would say, well, wait a minute. Just because you get alive in the ER, alive to the ICU, if you don't survive to discharge, that's no good. What Ricky would say is, if you don't survive the ER, you never survive to discharge. So you got to start somewhere. My counter to that is, unless what you're doing makes the early on endpoint look good and the later endpoint look bad. And I'll get into that in detail in just a little bit. How about ventilation? Do we actually need to ventilate patients? You know, how many here, if they're, you know, traveling down in the inner city of New York City and somebody's down on the street, would do mouth-to-mouth on them? Don't wait, just put up your hand if you're the one who, right. Nobody's going to do it, and that's what everybody knows. Nobody's going to do that. And so what the American Heart Association has said is that, you know what, it's probably just as good to just do compressions, better than doing nothing. Or people forget how many ventilations they're supposed to do, and so they're afraid, if I can't do it right, I don't want to do it at all. And so there's a bunch of studies in here that, as good as they're going to get, that you really probably don't need to ventilate them. You know, the outcomes here are so miserable anyway that they're not any more miserable if you don't ventilate. So they say, as a public policy message, just be sure that they compress them. And they did a controlled study where the dispatcher tells them what to do, and sometimes they tell them to give ventilation, and sometimes they tell them to just compress them. And the outcomes are small, but they're no different.
Pediatric data. So it seems like breathing
Breathing is better, is more important for kids because it's a lot of times respiratory. No, none of these are pediatric ones. So the American Heart Association recommends that. In one here, they found standard CPR was a little bit better. So the conclusion of all those studies is that some of them don't find it any better. A few find it maybe a little bit worse, but on average, it's probably as good as it's going to get to not do ventilation. All right. How about priming the pump? There's first of all an animal study here. That's the idea that by compressing the heart, you're getting it ready to be defibrillated, and you're doing something that changes the electrical activity so that your defibrillation is more likely going to be successful. And I think for most of these things, ignore animal study. One of my quotes that I use in that, to take home whenever we look at animal studies when we're clinicians, everything that's ever been tried and failed in humans has not only worked in animals, but worked spectacularly well enough that you could get a study in humans. So, you know, just the fact they say, well, we do it in dogs and that kind of stuff, and therefore we had to try it in humans, that's not unreasonable. Okay, let's try it. But just the fact that it works in an animal model, I don't think means much at all. I remember in the old days, my initial training was in neurosurgery, and when we were studying intracranial pressure, one of our residents had what they wanted as a dog model where you put in a catheter and pump in saline, raise the intracranial pressure, and do lots of things. You know what happens to a dog when you raise intracranial pressure? They leak CSF out of their mouth. Or out of their nose, rather. It's a protective effect. Or go take a dog and ligate both their carotids and both their vertebrals. They can still attack you. They have other collateral. So animal models, I'm not too impressed with. All right. Before and after, before and after. So a bunch of these studies that look at it. There's an Australian study here. Actually, so some of the anecdotal studies say, when we tried this and just gave them a couple of minutes of pumping before we defibrillated, especially if it had been a long time that they were down, more than 5 minutes, is what they said. It seemed to work better. Those were observational studies. Then the Aussies did a bunch of controlled studies where they randomized them to that kind of stuff, and they didn't find it was any better at all. So I think there's mixed results. The observational studies say, well, maybe a little bit of pumping works, and the controlled studies probably show it doesn't work. Termination of resuscitation efforts. This is actually, I think, an important issue for us. How many here have a protocol in their jurisdiction where they can terminate resuscitation in the field on a protocol? Yeah. I'll tell you, years ago, we had one of our paramedics badly injured and a lot of disability after running lights and sirens on somebody with a traumatic cardiac arrest in the field in asystole. And he even came back and said, you know, you guys have been telling us for years nothing works in traumatic asystole in the field. How come we're running lights and sirens? You know, and he's got a lot of disability. And at that point, we came up with a protocol that says if you're dead in the field, you're dead. And so most of all of these studies talk to that. One here is in Canada where they said, you know, an awful lot of times these patients had DNRs and the ambulance showed up and they did CPR on them. And a lot of times it was because they'd called the primary care doc and he said, call the ambulance. And then when the ambulance comes, they say, well, what are you calling us for if you're not going to have us do CPR? So I think it is a good thing to do. There is nothing more dangerous than driving in an ambulance, lights and sirens, around the city, through intersections. It's dangerous to the drivers of the ambulance, the paramedics, any patient or family that's in the ambulance, and all the passerbys. So if it's not going to work, we need to stop doing that. So now, how can you decide who it's not going to work on? And so there's this, there's these scores that they look at. Ontario did this, and they have what they call the BLS variables. And they say if the event was not witnessed by EMS personnel, there was no use of an AED or a manual shock in the pre-hospital setting, or no pre-hospital return of spontaneous circulation. That's one set of criteria. The other set of criteria included those three, plus it was not witnessed arrest by a bystander or with no bystander CPR. And what they did is they looked at that and said, how often do any of those people actually survive? 0.2% was the number. Actually, those that did well. With those actually would not have been ruled out by the BLS rule, but they would have been ruled out by the ALS rule. So they say, you know, it's really pretty good. Another one also done here in Toronto did the same thing and came to the conclusion that if they fit those criteria, terminated in the field, kind of thing. And then 30 looked at saying, well, there was a law, at least as of '99, that Medicare said that you can't charge for pre-hospital services unless the patient's transported to a hospital. So you got to run lights and sirens so you can bring them in, kind of thing. Does anybody know if that still applies? I don't think it does, because I know in our county, if they don't make it in the field, we either don't hear about it, or we've just heard, you know, the families come in here, let them know what funeral home to go to, that kind of thing. That's it. Defibrillation waveforms. So you can have, now there's evidence that if you have a biphasic waveform, you can use less energy to defibrillate the heart. And that's what implanted defibrillators use. They use a biphasic waveform because it works with lower energy. That's that rationale for that. They only have a certain size battery. So does this work better if your defibrillator has a biphasic waveform? Answer, no. Doesn't do any better. You don't have to throw out the old defibrillators. Okay, ACLS drugs. Do any ACLS drugs work? Magnesium. It's got to be good for something, I'm telling you. Answer, no. None of them worked. And we've known this for years. So the first one here was bicarb. You know, we got to use bicarb for something. You know, other than alkalizing your lidocaine or your other stuff, what else is it good for? Because for most acidosis, you don't need it for anything else. So what they did here is a funny study, and I only mention it because of how funny it is. This is a French study where they said, let's look at hospitals that use a lot of bicarb in resuscitation and hospitals that don't. And the hospitals that use a lot of bicarb, they have better resuscitation results. But they didn't actually look at whether the patients that survived were the ones that got the bicarb. It was sort of a system issue. So maybe they do other things as well, too. Maybe they put pacemakers on all these people. I don't know, but I thought that was sort of a crazy thing. Another one using bicarb improves in prolonged pre-hospital cardiac arrest. More of them lived in the ER, but nobody lived more getting out of the hospital. A before and after epi study. They took epinephrine out of the ambulance, and no difference in resuscitation rates. 38, I want to point out here. This is the old high-dose epinephrine stuff. How many here got on the bandwagon with high-dose epinephrine when it first came out? It's like a lot of things. You got to use it right now before we prove it doesn't work. But that was the stuff with, so look at this. They compared up to 15 standard doses, 1 milligram of epinephrine. This is number 38 right now, or 15 5-milligram doses of epinephrine. Holy shit. It didn't work. High dose didn't work. Has anybody here ever given somebody just half a milligram IV bolus of adrenaline? I did it by mistake. I mean, I didn't do it. The nursing did it. A guy with bee sting anaphylaxis. And I ordered half a milligram of sub-Q epi, and the nurse gave it IV. Holy shit. This kid goes, oh, my head. And I went, oh, my head, you know, and his chest. And I mean, that was half a milligram. You're giving people 15 5-milligram doses. See, I think that's my part of the link in the chain stuff, is if you could get these people their heart to beat while they're in the ER, you would say that's great. But what do you do to their brain and all their other organs? Think about what that must do to people. They must shut down every organ in the body when you do that. And if you can get the heart to live for a few minutes in the ER, you would say that's good news. That's the trouble I have with this links in the chain. Let's just try to get them to survive to ER. Let's just get them to survive to the ICU and not look at to discharge. Epi and intubation didn't work. Vasopressin doesn't work, no matter what the American Heart Association says. AHA guidelines. You know, I have been teaching this stuff for, you know, well over 25 years, and I have a rule that I've come up with. If the American Heart Association ever puts it in a guideline, you can bet it doesn't work. And you can bet there's evidence to that effect at that time that it doesn't work. It's really crazy. So amiodarone. You know, they approved amiodarone without any evidence that it worked. Here they said you don't even need to dilute it. Well, it doesn't work anyway, so who cares? They didn't get any hypotension. That's because nobody lived in it. So I didn't have any trouble with that. So amiodarone, interesting, they mentioned a bunch of what I call disease-oriented measures. You know, do you have a pulse? Do you get to the ER? All that kind of stuff. But the only patient-oriented outcome, survival to discharge, was no better. That's why when Billy wrote his conclusions here, that's the one that I actually disagreed with. Aminophylline. You know, we got to use aminophylline for something. I mean, now that it's no good for anything else, we must have some laying around and use it. Let's do it for asystolic cardiac arrest. Doesn't work for that. Bradyasystolic arrest doesn't work for that. How about putting drugs down the endotracheal tube? Doesn't work. Well, it doesn't work because it doesn't work even if you give it IV. So that's why. So this is number 49. Do advanced cardiac life support drugs increase resuscitation rates from in-hospital cardiac arrest? This is 1998, and we knew it didn't work. You know, it's really amazing. Paramedics, this was a Scottish study where they just said, you know, it doesn't matter whether the paramedics have any cardioactive drugs in the ambulance or not. And then the last one here is, I think this is Ian Steele's, Ontario Pre-Hospital, where they said ACLS, you don't need ACLS ambulances either. Works just as well. So pretty much my summary here, everything is time to getting to them. You're wasting your time by putting drugs in the ambulance and all kinds of other stuff if you can't get there within 5 minutes or so. So that's what the system ought to do. Then bystander CPR works better. All these effects are small. Bystander CPR is better than none, and compression only is better than doing anything else. And everything else really doesn't work much. And I think that's pretty much the conclusions here. I question number 5, whether this priming the pump thing worked, and 11, I don't think amiodarone works at all. Questions, comments? I will pick up on part 2 tomorrow morning.